Hi and welcome to Pharmacology Crash Course, where we will be helping you understand major topics. So today's topic is glucocorticoids. So first off, what are glucocorticoids? They are a class of corticosteroids that have anti-inflammatory activities, therefore are commonly used in the treatment of chronic inflammatory diseases such as asthma and rheumatoid arthritis. So within chronic inflammatory diseases, inflammation is a result of increased expression of inflammatory proteins caused by the activation of pro-inflammatory transcription factors, NF-kappa B and AP1. Therefore, the use of glucocorticoids regulates their effects by either increasing expression of anti-inflammatory proteins or downregulating their pro-inflammatory proteins. How glucocorticoids regulate their anti-inflammatory effects is via modulation of gene expression of inflammatory proteins by activating the receptors within the cytoplasm of inflammatory cells. They can modulate their effects through two mechanisms. First, by transactivation, that is the binding of the activated glucocorticoid receptor, homodimer, to glucocorticoid response elements in promoter regions of genes to stimulate the upregulation of anti-inflammatory proteins such as annexin-1. Or transrepression, where glucocorticoids bind to the activated glucocorticoid receptor monomers, which inactivates the key pro-inflammatory transcription factors such as NF-kappa B and annexin-1. This interaction results in the downregulation of pro-inflammatory proteins such as TNF-alpha and IL-1. Within asthmatic people, inhaled corticosteroids are used as preventers, either in low doses or in combination with relievers like salbutamol, or switch to combinations of inhaled corticosteroids and long-acting beta-2 agonists such as salmeterol. These actions will inhibit gene-regulating expressions of COX-2 and most inflammatory cytokines by decreasing eosinophil activation, upregulate expression of annexin-1, A1 to inhibit phospholipase A2, reduce Ig antibodies to directly decrease histamine release from mast cells, promote neutrophil penetration into endothelium, or to reduce symptoms of secretion, swelling, and inflammation. However, no direct effect on bronchospasm. So, pop quiz, let's test your knowledge. Now coming back to drug interactions, in asthma, glucocorticoids and long-acting beta-2 adrenal receptor agonist interactions are commonly used as treatments, with glucocorticoid acting as an anti-inflammatory drug and LABAs as bronchodilators. So LABAs potentiate the anti-inflammatory effect of glucocorticoids by exerting additive and synergistic effects, while glucocorticoids can potentiate beta-2 agonists by upregulating beta receptor numbers or through the prevention of receptor uncoupling in response to inflammatory stimuli. Another benefit of the interaction between LABAs and glucocorticoids in asthma is the ability to reduce angiogenesis, a feature of airway remodeling. It is also thought that LABAs potentiate the effects of glucocorticoids in reducing inflammation and preventing remodeling in chronic asthma. Despite the benefits which glucocorticoids exert as an anti-inflammatory drugs, patients who are receiving glucocorticoids are susceptible to invasive fungal infections, which are associated with high morbidity and mortality rates. Triazoles, such as itricanols and vorcanols, are effective in the treatment of fungal infections in its potent activity against a wide range of pathogens. Unfortunately, the co-administration of triazoles and glucocorticoids has shown to have some difficulties due to its drug-to-drug interactions. Glucocorticoids are mainly metabolized by CYP3A4 and vorcanols inhibits CYP3A4. In the clinical aspect, it is beneficial to avoid high exposure to glucocorticoids, as this is often associated with systematic adverse effects such as diabetes mellitus, electrolyte disturbances, loss of bone density, as well as an increase in cardiovascular events. There are many adverse effects associated with the use of glucocorticoids, commonly seen in chronic use of the treatment, and therefore the seen adverse effects are dose and duration dependent. Osteoporosis is one major adverse effect as a result of glucocorticoid use, as well as the inhibition of bone formation being observed in patients taking glucocorticoids due to increased apoptosis in mature osteoblasts. Glucocorticoids is also found to induce diabetes mellitus, a disease that prevents the body from utilizing glucose, and this can either be type 1 or type 2 diabetes. Cushing syndrome is also another adverse effect. It is caused by prolonged exposure to high circulating levels of cortisol when taking the glucocorticoids. This results in the redistribution of fats, consequently resulting in tropical obesity, buffalo hump, and moon phase due to increased glucose metabolism. Hypertension is also observed with glucocorticoid use, however the mechanism still remains unknown. Long-term glucocorticoid usage is usually associated with dyslipidemia and is characterized by elevated total cholesterol levels, low-density lipoprotein, cholesterol, and triglycerides. Thus, physicians should consider reasonable and appropriate use due to the major adverse effects associated with its use.